get into it. Hello, hello, hello. Welcome everybody to another episode of Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Lexicon Pharmaceuticals. I will be your host. I'm getting tangled up in my headphones. My name is Rain Bennett. I'm a filmmaker, and I've been working with CCF for almost 10 years. I can't believe it's been that long, but it's been a really profound journey for me. I've enjoyed every moment of it, and learning about this disease and becoming a part of this community. It's been one of the highlights of my life, and I mean that sincerely. And what I do is I help CCF create video content that helps spread awareness and education about NETs. As we know, that's I think our first line of defense in approaching and attacking this disease is understanding it, and that's the thing that I've seen. That common thread that I've seen through any of the experts that we've had on the show. If you are just signing on, you probably know the deal. Let us know where you are in the world. Nepal, we already got AJ from Nepal. Welcome back. Good to see you. Let us know where you are in the world. Say hello. We love to see the reach that we have, and hopefully, you've got something tasty to eat or drink with you. It is Luncheon with the Experts after all. I'm not a nutritionist. We do have nutrition videos that the Carcinogenic Cancer Foundation and I have produced. They're right here on the videos tab. We also have a Facebook Live that we've done. But I will say from my years of personal training that we're all different and all require different types of nutrition, especially if you're dealing with the disease. So understand what works for you and your body. That's my bit. That's all I know to say. So before we get started, I just wanted to say that Luncheon with the Experts is a series made possible by Lexicon Pharmaceuticals. We are very grateful to them for their support. We have a little disclaimer we like to say at the top of the program from them that says the opinions expressed by the guest presenters, as well as the questions asked by the audience, have not been created or suggested beforehand by the sponsors of the program, and CCF doesn't endorse nor promote any of the views, opinions, or information provided in the presentation. And audience members should not rely solely on the opinions or information expressed and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that just means, while we hope to give you some really valuable information today, we don't know your case specifically, and you need to make any decisions with the team that knows your case specifically. Today's guest is Dr. Charles Nutting. Welcome to the show, Dr. Nutting. How are you?
I'm doing great. Thank you very much, Rain.
Absolutely. Dr. Nutting is joining us from Denver, and we just discussed that there was a 63-degree swing in temperature in the past day. Is that true?
It was crazy. We were playing tennis one day, and then the next morning we had snow on the ground.
That is wild. I saw it on national news last night that Denver has, like 4 inches of snow.
Yeah, crazy.
Which is bizarre. And then it's cooled off a little bit in North Carolina, but not quite that much. So tell the people, Dr. Nutting, where you work, a little bit about yourself and your role in this community and facing this disease and what it is you do.
Sure. Thanks, Rain.
Absolutely.
And I'd like to thank CCF for inviting me to speak. I'm an interventional radiologist. So I perform minimally invasive surgery with X-ray guidance. And, the big joke is my mom really still doesn't even understand what I do. But it really is kind of this minimally invasive surgery. It's a quicker recovery for patients, less side effects, get them in and out of either the clinic or the hospital quickly. I trained in Chicago, then worked in Arizona for a while, and have been in Colorado for 15 years. I've been part of large radiology groups, small radiology groups, and now I'm part of a relatively smaller clinic where we perform procedures outside of the hospital setting in a safe fashion. I work with the Neuroendocrine Institute with Dr. Eric Liu and Alan Cohn. And all the patients that we treat are discussed in a multidisciplinary fashion with everybody presenting their expertise to give the patient really the kind of the best outcomes and to play the cards in the most appropriate fashion. Because many of these therapies can be performed. Usually the art in the whole thing is which one gets done at what time frame, what gets done first, does one preclude anything else in future algorithms. So that's a very common discussion that we have. The tumor boards have really kind of taken on more of a virtual Zoom type feeling. We're still not meeting routinely at this point because of COVID.
Does that cause any obstacles that you have to overcome not being in the same room together, or is it effectively the same for you?
Yeah, actually, I think that's probably one of the improvements that have come out of COVID is that the technology is very good. The screen sharing is good. We're able to look at pathology slides, imaging studies simultaneously. So it's a good substitute. There's nothing like being there in person, but
Sure.
we can transfer a lot of information quickly.
Well, that's good that that hasn't been affected too much because as you've already said, and we know here at the foundation that part of this of addressing this disease is crucial. And I know that that multidisciplinary approach is important for people to understand. And there's a lot of questions that we always get about it. So I think we'll probably put a pin in that and definitely come back to it, as well as the sequencing, which you mentioned. These are questions that we get a lot about. So I'm glad that you've already said that. So everybody at home, go ahead and send in your questions now that we've learned a little bit about Dr. Nutting and how he serves this community. Just know that we won't be able to get to all your questions. We're going to try our hardest, but you guys always have so many, which is exciting to us, that unfortunately we can't always get to all of them. So if we don't, I suggest you follow up with Carcinoid Cancer Foundation, either here on their Facebook page. You can send them a direct message, or at carcinoid.org. And actually, before we leave, Dr. Nutting has said that he would give us information for you to reach out to him as well. Is that still accurate, Dr. Nutting?
That's correct, Ray.
All right, and that's very kind of him to do so. So, and that being said about your questions, just know that, as we've already said, Dr. Nutting isn't working with your case specifically. So try to ask your questions in a way so that he can give a general answer that gives you guidance. Okay, if we get too much information about your specific case, he's not your doctor. He doesn't know your case. It's really hard for us to help that way. So just keep that in mind when you're asking questions. And another thing, I mention this every week. If you see a question that someone else is asking, because I really love the community that exists in the comment section of the Facebook Live program. If you see a question that you also have, or you think that is important, you can just like it or love it, or just click that, click one of those emojis that let me know that there's more interest in that, and that will kind of, help upvote it, if you will, so that when I see that question, I'll know, oh, there's multiple people that want this answer, and that will help me get to all the questions that we want to. Okay, so before we get started, just want to say that we know how challenging it is to be a NET patient, especially a person seeking diagnosis in a time like we are now, still in this pandemic. And CCF is here for you whenever, however you need us. And if you'd like to show support in return to CCF, an easy way that you can do that with a small donation, or a large one if you want, is to text the word experts to 1-914-380-7323. That's experts to 914-380-7323. And every donation genuinely helps, and it helps us continue to create programs like this. So go ahead and send in your questions. I see that we have some already. We have some people. Tonya says cold in Colorado. That is for sure.
The fireplace is on.
Right. That's so strange. I guess not so much for Colorado, but still, it's September. That's wild.
Yep.
Before we get started, I want to go ahead and get back into that. I mean, not before we get started, but before we start taking questions. As I've already said, we talk so much about the multidisciplinary approach, and you made it clear to me when we did our test earlier in the week that, like, you don't, and forgive me, or correct me if I'm wrong about how I word this, but you don't consider yourself a quote unquote NET expert, but rather a role player in this team, this tumor board, this multidisciplinary team. Can you tell me a little bit more about the role you play, where you fit into the team, and the importance of the team? Because now we know, and every doctor and every expert has said, like, this is the best way to approach this disease, is by having this multidisciplinary team established.
Agreed. And I think the patients, actually, I think the patients are their own best advocates and probably get the best care as they do their research. The multidisciplinary team is a way for, nobody can know everything about everything, but we can definitely lend on each other's expertise. At my institution, Eric Liu and Alan Cohn are the medical and surgical oncologists. I consider them the quarterbacks of this whole team. And I just happen to be pulled in for a couple of plays, give my thoughts and skills, mainly to treat liver tumors. That's really what I do, whether it's a local or regional therapy, and we could talk a little bit about that. But it is patients who are discussed in a multidisciplinary fashion really get the best expertise from everybody at the table. So I've treated probably 1,000 neuroendocrine patients at this point in my career. So I am kind of an expert in neuroendocrine and liver-directed therapy. But I would say that medical and surgical oncologists really are the ones that drive the therapies. And then I try and figure out how they interact with some of the things that we may be doing in the liver specifically.
I got it. That's, go ahead.
I would just say, if I don't know the answer, I'll tell you that I don't know the answer because I know that these are very educated patients, and many of them with more knowledge than I have in specific areas. So I don't mind saying I don't know.
I got you. I really like the football metaphor, the quarterback metaphor, because, everybody in their position ostensibly is an expert, right? If you're a wide receiver or left tackle, like you want to be the best of the best in that position. But I like that concept. It really visually illustrates it for me that, but you still have someone that's kind of leading the team, and the plays are based around them. So I think that does a good job, for me at least, understanding the dynamics of the team and how they operate. Everybody's an expert in their field, but you have to have this cohesiveness to come together as a team to really make progress down the field, so to speak.
Agreed.
Yeah. Okay, let's start asking some questions. Tell us where you are in the world. We're already getting great people here. What are your thoughts on this is a question when it comes back to radiation that I've heard a lot. What about people that are cautious or concerned about radiation when it comes to their treatment? Is this something that you've dealt with patients?
Well, I think there's different types of radiation. Some of the radiation is generated by the equipment that we need to perform the procedures. Mm-hmm. And I don't consider it a necessary evil, but that's how we do a lot of our imaging. I think that the question is, is radiation carcinogenic? Can it cause tumors? It can. I think typically in the doses that we're using, that's not a realistic concern. I think it's more important to get frequent scans to look at the tumors and make sure that nothing's progressing. And if it is, then to address that early on. Obviously, MRI does not produce any radiation, but many of the procedures that we perform cannot be performed under MR guidance. Mm-hmm. Then that also leads into the radiation that you receive from the therapy. So Y90 Radioembolization is a liver-directed therapy that really is targeted at the liver itself. There's very little that goes outside of the liver versus PRRT, which is given intravenously and then accumulates in areas of somatostatin receptors. There are discussions about cumulative radiation dose over your lifetime. How much can you receive? Excuse me, and are there side effects with that? When I started out 20 years ago, we did lots of radioembolization with yttrium-90, whether that was Cersphere or Therasphere. And I think that those patients responded well. The tumors actually shrunk or stabilized probably 95% of the times. But what we're learning, and thank goodness, patients live a long time with this disease. But there can be some sequela, some long-term sequela of the treatments that we do. And what we're finding out over the last 5 years is that sometimes the radioembolization can cause, it will cause the tumor to shrink or stabilize, but there can be some longer-term effects in the liver, which may be portal hypertension, where some of the fluid accumulates in the belly, mm-hmm. That may or may not need to be drained. Only about 5 to 10% of those patients actually will know that there's a significant issue. Many times it's subclinical. So I think there's radiation from diagnostic studies, and then there's radiation from therapies. Obviously, the radiation from therapies is 1,000 times higher dose than what we see in the diagnostic setting.
Got it. Before we move on to start taking questions from the audience, I wanted to revisit the multidisciplinary team concept, and we may do that frequently throughout the program if people have questions. But in your opinion, who are the must-have members of that team? Who are the ideal members of that team?
I think that each team's going to be a little bit different, but the necessary players are medical and surgical oncology. There's usually a NET expert. And that's one thing, is NET experts can be really different specialties. Eric Liu is a surgical oncologist. Dr. Alan Cohn is a medical oncologist. So I think medical surgical oncology, pathology, a pathologist is important to have in the room as well. A diagnostic radiologist, somebody that can read the images, and then an interventional radiologist to kind of help put together some of the therapies that may be liver directed or outside of the liver. There may be social service involved as well, nurse practitioners, PAs, really the whole team taking care of the patient.
Got it. And a couple of times now, Dr. Nutting has mentioned Dr. Liu, which I know many of you out there know, and we're friends with here at the foundation. He was on last year's version of, it wasn't Luncheon with the Experts, but it was a Facebook Live program. And he's awesome to work with. I don't know Dr. Alan Cohn personally, but I've worked with Dr. Liu a couple of times. So I know they have an all-star team there in Colorado. So we're happy to have
Dr. Liu usually needs more than just one lunch hour. He's so good.
Yeah, we veered off on the program we did and started nerding out about Star Wars, and then came back and started talking about nets. But he's outstanding. So shout out to Dr. Liu out there in the world. Hope he's doing well. So we're getting a lot of questions, Dr. Nutting. So I want to go ahead and start fielding some of those so that we can help the people out there. Okay, so Bet says. It gives a little bit of context about her personal diagnosis, but essentially the question is, how often do you recommend following up on scans?
Yeah, that's a good question. And the question is, what type of scan? Mm-hmm. Most of the gallium scans, I would say, are done annually to a little less frequently than that. And that depends if you're gallium positive or not. If we're talking about, and the nice thing about a gallium scan is obviously you're looking at the entire body, whereas a CAT scan or an MRI is usually specific to a region. Some people do get whole body MRIs, probably more accurately whole body CAT scans. Mm-hmm. Many times what we're seeing is targeted imaging to the liver or to the area of the primary tumor. So CT imaging of the abdomen and pelvis. And those are usually done on an annual basis, unless a therapy has been performed and we're looking at response to therapy. Many of our liver-directed therapies like chemoembolization, bland embolization, radioembolization, we would probably wait about 3 months before we do follow-up imaging. And I think that's an important thing to say. We know that it takes about 3 months for these tumors to actually shrink down in size. Early on imaging, we'll see that tumors actually swell up or get bigger. We know that tumor markers go up in the short term. So if we see something that has increased tumor markers and is getting bigger, that's usually progression of disease. But in reality, we wait another couple months, get the imaging done, and we see that the tumors are shrinking. And usually at about 4 to 6 weeks, the tumor markers are coming down as well. So you have to wait it out a little bit. And I think if you get early imaging, there may be a reason to do it. It may not be to look at the liver tumors. It may be that somebody's having abdominal pain. And I think it's valid to do that, but I really wouldn't trust the response of the liver tumors until about 3 months after the therapy.
Got it. Thank you. Hopefully that helps, Bet. Appreciate your question. I've got an interesting question from Sandy. I haven't heard about this, but she says, could you talk about the use of melatonin as a sleep aid and NET patients? I've heard that we shouldn't be using it. Any thoughts or knowledge about that?
Rain, I don't know anything about that. Yeah. I'd be happy to research it and maybe post it, but I don't know the answer to that.
No, that's okay. I didn't either. That's why I thought it was an interesting question. Sorry, Sandy, but if anyone does have any thoughts, again, I've mentioned this already today. I really like seeing in the comments how the patients and the people watching the program share their experience and share their stories with each other. So Dr. Nutting and I aren't really familiar with that, Sandy, but maybe someone is. So I appreciate you asking the question. And if you have further questions, hit us back up. Question from Lynn about pancreatic nets. If a pancreatic net is not hereditary, how does a cell mutate?
I think you're really testing my my medical school knowledge there. I don't know that I could intelligently answer that.
Got it.
Yeah. I mean, we know that these cells can mutate. I'm not sure exactly how the pancreatic tumor itself mutates.
Understood. Understood. Okay. If you have a follow-up question, that Len, just let us know. Got a question from my old friend Pat Murphy. How you doing, Pat? Good to see you. There's been some discussion in the net community about the use of CU64 scans. Have you any experience with them? Are they covered for Medicare or insurance purposes?
So we don't have CU64 scanning, to my knowledge, in Denver.
What is that, by the way?
It's an isotope that's used for PET imaging,
Okay.
or SPECT imaging. But other than that, we just don't have experience with it. So I feel kind of silly, but I don't know the answer to that question.
No worries.
How about a liver question? Anybody got a liver-directed therapy question?
I got a liver question.
Okay.
We had talked a little bit in our test about, as I've said earlier, about what exactly you do in this realm and what you don't do. And one of the things we talked about is non-surgical liver directed therapy. Could you tell us a little bit more about that and what exactly that is?
Yeah. So non-surgical therapy is really kind of interventional radiology. So most of what we do is using image guidance, and whether that's local therapy in my mind is putting the needle in something using either a CAT scan or ultrasound guidance. So if a patient has 1, 2, or 3 tumors that are usually less than 3 centimeters in size, then we can bring the patient into the hospital, get them sleepy and comfortable, may or may not have a general anesthetic, but actually put these needles through the skin into the area of the tumor, and then burn, freeze, or shock the tissue itself. Unfortunately, most NET disease is not focal like that. So that's considered more of a regional therapy. And as an interventional radiologist, I look at segments of the liver, right side of the liver, left side of the liver, and there's 8 segments within the liver itself. So I try and pinpoint which areas need to be treated. In most patients, it's diffuse disease spread throughout the entire liver. Now that may be 3, 4, 5 tumors throughout the liver. It may be too many to count, and very small disease. So in that situation, the liver has a dual blood supply. It's supplied by the portal vein and the hepatic artery, and actually gets most of its blood supply from the portal vein. We know that liver tumors, especially from neuroendocrine disease, recruit up to 100% of their blood supply from the liver artery. So the therapies that we deliver, usually through an angiogram, where we're looking with X-ray guidance, almost like a cardiac catheterization, we go in through the wrist or the groin, go up into the liver, and then find these segments that supply the tumors. And in our setting, many times we'll treat the right side first, which tends to be the larger portion of the liver, about 70% of the liver volume. Left side's about 30%. And we will do an embolization into the right side, relying on the hypervascularity or increased blood supply of the tumor. As we dribble in these beads, whether they're radiation or just bland beads, they get sucked up into the tumor. They starve the tumor of their blood supply, which causes it to die over time. Now, the residual liver tissue does not die because it's being supplied by a different system, which is actually the portal vein. So the idea is we stratify into local therapy or regional therapy, regional being through the artery. And then once we talk about regional therapy, we look at bland embolization, which are just particles. There's chemoembolization, which are particles mixed with chemotherapy. There's also drug-eluting beads, which are beads that soak in chemotherapy that then get delivered. And then there's radioactive beads as well. So the decision is, what would be best for that patient at what point in their disease process.
So what's the recovery process like for those therapies?
So it's all a little bit different. I would say with a burning or freezing technique, that's usually 23 hours in the hospital and the patient is discharged the next day. If we're doing a bland embolization, which is where we're just putting particles that starve the tumors of their blood supply, that creates some pain. And Dr. Liu tells my patients that they're going to experience the worst pain of their life. I don't think that that's necessarily true, but I think if we, tell them the worst thing that can happen, then anything else better than that is good. But as you're starving it of its blood supply, there's things that we can do. We could put some numbing medicine inside of the liver. We could start some of the narcotics before the procedure. I would say most of the time during the procedure, patients are very comfortable. It's usually within that 3 to 4 hours after the procedure that they start having some pain. And it's called post-embolization syndrome. It's a very well-known issue that happens with patients as you starve something of its blood supply. They can have some mild nausea, which we use Phenergan and Zofran for, so either suppositories or oral medications. They could have some pain, usually in the area of the embolization itself. So, we use narcotics. Sometimes we're using a fentanyl patch where they can put it on their arm and get some of that medicine in their body before they come to see us. And then we use narcotics orally afterwards. Probably 10%, maybe less than 10% of patients actually end up being admitted to the hospital after the procedure. Most patients go either back to their hotel or home and are maintained on oral medications. It's important to stay very hydrated, especially here in Denver, but I think many of these patients that are taking narcotics end up getting constipation just from the narcotics alone. So I think good bowel maintenance is important with Dulcolax, with staying hydrated, and enemas if needed, because it really gets, it adds a whole nother set of issues to the recovery once patients start getting constipated. They're just miserable. So I think if we work on that from the beginning, it's helpful.
Are any of these, are these one-time therapies, or are any of these something that someone would do again?
So many of them are therapies that would be repeated over the patient's lifetime.
Okay.
And just for our clinic, we usually treat the worst, probably the most tumor burden first, which tends to be the right side. And then the patient would go home and come back about 4 to 6 weeks later, and we would treat the left side, which is typically better tolerated because it's a smaller liver volume. Those patients would then tend to get follow-up imaging at about 3 months. Okay. And it's not uncommon to see disease stabilize for months to years, depending on the patient and therapy. And then if there were something else that were to come back, we may target our therapy based on what that next scan shows. So it's uncommon to do these procedures over and over and over. It's usually do the procedure, look for stabilization. If there's progression, then do something else. And it may be that we start with a bland bead or chemoembolization. I think we're really trying to stay away from whole liver radioembolization at this point because of some of the portal hypertension that can occur. So with Dr. Liu, it's not uncommon for me to, maybe if the patient has a large tumor that's difficult to resect, it's in a hard place to get to, maybe at the top of the right side of the liver or by the heart, I may treat those with the radioactive beads and then treat the rest of the liver with the bland beads. So those are the types of discussions that happen at the multidisciplinary tumor board on the best therapy for that individual patient based on the type of tumor and the location. And then how does PRRT and some of the other therapies play into that?
Yeah, absolutely. I'm sure we'll get some questions about that too. Everybody, well, first of all, I want to say to everyone listening, I see that periodically you're sending the little thumbs up emojis and the hearts. That's a great way to let us know that that we're doing our job and we're giving you some value. So if Dr. Nutting is answering a question that you were looking for, that's an easy way. Just send a little thumbs up or a heart emoji and let us know we're doing our job. I want to get back to some of the questions from the audience because we have a lot. We have one from Wendy. It says, Dr. Nutting, I'm a fighter. I'm mad. It took me 15 years to get a diagnosis. I'm sorry to hear that, Wendy. And unfortunately, you hear those stories with this disease often. I go to UC Health PNET with metastases to liver and going on palliative care. No treatment. What are the types of things I can expect going forward?
So, yeah, I'm sorry, Wendy. I mean, that's such a tough situation. I think it depends on where the tumors are. More than 50% of the time, patients will develop hepatic or liver metastases, and usually liver ends up being the biggest threat to life because as the tumors start to grow, they push the normal liver tissue out of the way, or they can obstruct or block off some of the bile ducts. So really the therapies are to try and help preserve liver health as best possible. I don't know exactly where Wendy's tumors are or what makes her untreatable. I would say that we do look at patients to make sure that they would be able to tolerate these therapies. So we don't want to do things that are going to make people sick and not recover. Sometimes that is liver function. If we're looking at the liver and the total bilirubin, your liver acts as a filter, processes all these things and produces bilirubin. As the tumors start to replace normal liver tissue, the bilirubin can go up. Mm-hmm. As these tumors start to block off structures, the bilirubin can go up. Usually that can cause some itching, can cause yellowness of the eyes or skin, can make people more somnolent. The ammonia levels can go up as well. So, unfortunately, the liver can fail at some point, which usually starts to see some fluid in the abdomen and confusion with encephalopathy.
Got it. Thank you. Thank you for your answer there. And Wendy, thanks for your question. Hope you're doing okay. Just know that we're fighting with you. Next question from Deanna. Well, first of all, are you familiar with the TACE method, TACE?
Yes.
So Deanna says, how effective is and would you recommend the TACE method? And let's for those that aren't familiar, like myself, let's establish what that is.
Sure. So TACE just stands for Transarterial Chemoembolization, TACE.
Okay.
And that differs from Transarterial Embolization, which is the bland bead. So once you put Chemoembolization in there or chemotherapy, it's called TACE.
Got it.
And I think that that's a great question. Right now, you could find almost any literature supporting whatever you want when you talk about TACE versus bland embolization. And there are some papers that showed that bland embolization without chemotherapy was better. There were other therapies that showed chemotherapy with embolization or TACE was better. So Dr. Sulin out on the East Coast is actually doing a good study right now, very hard study, which is a multi-institutional randomized controlled study, really the gold standard, to look at chemoembolization versus bland embolization versus these beads, drug-eluting beads. And I think they have maybe 60 patients in each arm. The drug-eluting beads were pulled off the study last year because there were some increased adverse events. So I would say that most people are not using these drug-eluting beads for treatment in neuroendocrine disease. When we look at chemoembolization, the procedures are actually very similar. It's going in through the artery in the wrist or groin. It's conscious sedation, so patients are comfortable throughout the procedure. It tends not to be a painful procedure, although some patients can have pain as these tumors' blood supply starts to block off. But they have an IV in and they're getting medication at that time. Chemoembolization is very good for a liver dominant problem. There's differing regimens. One of the things about interventional radiology is I would say we're not super standardized. The interventional radiologist may use their own chemotherapy cocktail. There are several cocktails available. There are several different types of embolic material. One is a thiodol or an oil that you can mix with the chemotherapy. The other is kind of a slurry of a gel foam and chemotherapy as well. So I would say that right now, bland or chemoembolization really is the standard of care for liver tumors. I think that chemoembolization is well tolerated. Most of the time it's done in the hospital, although it could be done as an outpatient. And it's really the same issues. It's to manage pain control and nausea, usually done with oral medications. And then my guess is you're probably either going to get one side done and then the other side done 4 to 6 weeks later, and then get follow-up imaging about 3 months after that.
Got it. Thank you so much.
Sure.
Hopefully that helps. Thanks for your question. We've got a lot of questions and a lot of people tuning in today, so that makes me excited, makes me happy. If you are just joining us, we're here today with Dr. Charles Nutting. Let us know your questions that you have. He's an interventional radiologist, and he has given us his time. We've got about 30 minutes left, and we're going to get to all your questions if we can. However, if we can't, follow up with CCF here on their Facebook page or at carcinoid.org. and share this with people. Let people know that this is available so that they can join us and get their questions in. And if they're not able to, or you want to refer back to the video, just know that it will be evergreen. It'll live here on the Facebook page under the videos tab. And starting Monday, we'll republish it to the YouTube channel for Carcinoid Cancer Foundation so anybody can access this.
So, Rain, I would just say that my good friend and colleague, Dr. Eric Liu, texted me back and said that the patients can take melatonin, that there's really no significant data saying that they can't.
Great. Unfortunately, I forgot the question asker, but hey, that's what I'm talking about with our net community. So we came through. Thanks, Dr. Liu, for coming through. Hope you're doing well out there and not buried in the 4 inches of snow. Real quick, we got a question from Barba, quickly, coincidentally. So after 5 years of everolimus, I had August 6th, my first PRRT, and had bad side effects. Basically nausea. Is there a way to help dealing with vomiting when you're having PRRT, or any advice for her with dealing with that?
So here in Colorado, people are using CBD and other things. I would say that there's nothing specific other than the traditional antiemetics like Kytril, Zofran, Phenergan, and I'm sure she's probably tried all of those. Mm-hmm. There is some data. It's called the P6 zone, which is just above the wrist. You'll see some of those bands that people wear for nausea if they're going out on a boat. Mm-hmm.
Oh yeah.
Some of our patients have tried that. We've actually injected saline in that location as well. It can help, but it's very hit or miss. Sometimes a scopolamine patch behind the ear, which is another kind of anti-motion nausea medication, can help as well. We've had good success with scopolamine patches with some of our procedures where we couldn't hold patients with the even the IV medications. A scopolamine patch helps. So I would say that's probably worth a try.
Got it. Thank you. From Susan, do you have any suggestions nutritionally for liver care radioembolization? Things you should eat and shouldn't eat?
Well, I could tell you what you shouldn't eat.
Okay.
And it's probably not even so much from a meal perspective as it is metabolism of the liver. And as most people know, Tylenol, acetaminophen, is metabolized through the liver. And I think with the liver being inflamed from the radioembolization, we know the half-life of the radioactive beads is about 64 hours. So we say that all of the radiation is out of the liver within about 2 weeks. So I think you should really minimize any Tylenol or acetaminophen products. I don't really know that much about from a food perspective. Some people say milk thistle, which is more homeopathic, but that can help with liver issues. Don't really have any experience with it. I do have, like this multidisciplinary discussion, I do have integrated medicine doctors in the community that I will send patients to who really specialize in that.
Got it. I had a question from AG. AG, there you are. It was asking, what are some of the tools in your toolbox for mesentery metastases?
Yeah, so that's AG. That's tough, and we know that there are desmoplastic reactions with these tumors. They actually create scarring and retraction of tissue, and I think it depends specifically, where you're talking about. We know that the aorta gives rise to the vessels that go very close and through the pancreas. Also, that's the mesentery, or kind of the root of where the bowel drains its blood and gets its arterial blood supply from. If there's blockage of arteries or veins, I would say surgery is the number one option, although a lot of times surgery is difficult in these locations. So we can stent arteries. Arteries tend to be a bit more resilient than the veins. They have kind of a thicker wall and more structure and under higher pressure. So if there were occlusion of an artery, we can go into that area, usually through the groin or wrist, and open that up with a balloon and a stent. Probably more commonly what we see is some of the draining veins from the gut, from the bowel and stomach that come into the portal venous system that drain through the liver and back towards the heart and lungs. That's where we start to see the issues. And as those veins start to clog up with this desmoplastic reaction, you tend to find extra pathways around, and that can lead to varices that can bleed into the stomach and abdomen. The procedures that we have, we can either, typically for these, we put people to sleep under general anesthetic, but we can either go in from the neck, or we can go in through the liver, put a tiny needle into those areas, inject some dye, see what's blocked off. And then we have devices that can actually suck out clot, as well as stent open some of these veins. Now, veins don't really have much rigidity to them. Mm-hmm. So as you start to see a scarring reaction around them, really, you can blow up a balloon, but you need to put in stents to keep those things open. Those are bigger procedures. They actually do work very well. We have a lot of experience with it here in Denver, probably because of maybe the altitude or dehydration. People tend to clot more, but we do see a fair amount of portal vein issues here.
Got it. Thank you. Another question. We have a question from Dale. Does liver embolization make sense to a patient who has dozens of tumors?
Yes, I would say that actually those are the patients that it probably makes more sense to treat. The great thing about this liver-directed therapy is I don't have to go into each tumor to treat it. I just need to get kind of to the artery that's feeding all of it, and make sure that it's deep enough in the liver that we're away from the pancreas and the gallbladder and some of these other things where we don't want the beads to go. But even if you have 100 or 1,000 tumors in the liver, these tumors are going to preferentially suck that blood into the tumor because that's how they grow. And they're going to suck these beads in there. The beads are of a specific size that they can't go through the capillary. Mm-hmm. So they actually get stuck in the tumors, where they exert their either radiation, chemotherapy effect, or just the ischemia or lack of blood supply that causes those tumors to shrink over time. So I would say, yes, that's exactly the patient that we treat, is somebody who has multiple liver tumors.
Perfect. Thank you. Hopefully that helps, and good luck on your journey. I have a question. Okay, this is from Patty, who lives in Canada. Patty says, I have several metastatic lesions on my liver. Currently, I'm on octreotide injections. What are your thoughts about a liver transplant?
Yeah, so it might be a little bit out of my area of expertise, but okay. I would say that most people do not get liver transplants for neuroendocrine disease. And the liver transplant, it's obviously a very big surgery. And there are complications of that surgery.
Sure.
Once you get a new liver, you have to be immunosuppressed. So you get put on medications that block your own immune system. My guess is that right now your own immune system is helping suppress some of these tumors at other places in your body. So when you get a new liver and your immune system is suppressed from these medications that you have to take so you don't reject the new liver, it allows tumors to grow. So we know in hepatocellular carcinoma, which is cancer that starts in the liver transplant is a very reasonable treatment and a cure in lots of patients. But there's criteria that you have to meet. 3 tumors less than 3 centimeters in size. Very well-established criteria, because we know if people have bigger tumors than that and get a new liver, they're the people that the disease will explode once they get put on immunosuppressant. So I would say not impossible, but uncommon to get a liver transplant. And really the therapy should be directed at keeping your liver as healthy as possible for as long as possible, and suppressing those tumors with some kind of therapy.
Got it. So she says she's currently on octreotide injections. Is there any other advice about how she could continue to keep that liver healthy and not have to look at maybe a transplant or something? Or keep doing what she's doing?
I think she's probably doing the right things. Octreotide helps suppress the tumor from growing, as well as lanreotide. And I think that because she knows she has disease in the liver, it's probably doing frequent surveillance. Mm-hmm. Frequent may mean annually, but make sure none of those tumors are getting larger quicker, because a lot of times these tumors, it's not just a homogeneous population of tumors, meaning that they're not all exactly the same. There can be some aggressive tumors, and there can be some more indolent tumors in the larger tumor population. So I think it's important to undergo the surveillance. And if something's growing quicker, you need to address that area specifically.
Got it. Okay, thanks. Good luck. Sending love to you up there in Canada. I have a question from Lou. It says, I had a gallium scan done with a radiologist who said there was consistent uptake throughout the full liver, but the MRI showed nothing. Should they continue to watch? What do you think?
So I would continue to watch. I think that MRI is very sensitive. I think a CAT scan is probably less sensitive, but an MRI is very good at tissue differentiation. And even if there's what we call miliary disease, which is lots of tiny tumors spread throughout the normal liver parenchyma, an MRI can detect that very easily. So I'm not sure the etiology of the uptake with the gallium scan in that particular case, but I think looking at both of those studies, the MRI would be better at tissue differentiation of small tumors in the liver.
Got it. Thank you. Good luck, Lou. Another question from another Lou. Can these embolization treatments be done outside the hospital setting and in an outpatient setting? And in this COVID environment, could it help reduce the risk for infection?
Yeah, no, that's a great question.
Yeah.
So we are trying to keep patients out of the hospital right now, just in general. So we have a standalone clinic where we do these embolizations and we do them safely in an outpatient setting. I always give the patient the option. They actually prefer to be in a clinic setting and not go to the hospital. So yeah, I think it is safe to treat these patients in a outside of the hospital setting. We use octreotide or sandostatin, just like we would do in the hospital. Patients have an IV and are being hemodynamically monitored. So they're getting the same care as they would at the hospital with the same types of medications. And I really think that it's the team that's important. So it's important that your doctor's treated a lot of patients that have neuroendocrine disease. It's important to know about carcinoid crisis and how to manage it. I would say that patient history is very important for us. If I have a patient that I know has had either a crisis during a surgery or a prior embolization, we usually give those patients IV octreotide, usually 100 to 200 micrograms IV slowly before the procedure. That tends to block any reaction that they would have. But if they are a labile patient who has lots of flushing, lots of symptoms, we would start an IV and have a continuous drip of octreotide going in as we're working. And as the symptoms start to pop up, it's kind of like an accelerator. We just open up the bag of IV fluids. There's more octreotide dripping in. There's really no limit to the amount of octreotide that we can give. But we titrate it or dial it in to the patient's symptoms. So I think it's important. If I were a patient, I would be asking your interventional radiologist before the procedure how he would manage carcinoid disease or crisis during the procedure, just to make sure that everybody's on their toes and that they're comfortable with the explanation.
Got it. Thank you. Question from Jennifer. Are there any adverse effects to having tumors from both lobes being embolized at the same time? My IR did all of them at the same time.
Yeah, I wouldn't criticize that. I think it depends on the type of therapy.
Mm-hmm.
And usually the reason that we treat one side first and then the other side is because it can hurt. The recovery can be longer. With a bland or a chemoembolization, where the idea is to really starve the tumors of their blood supply,
Mm-hmm.
Patients probably would not be able to tolerate the whole liver being treated at once. Whereas with radioactive beads, because the idea behind bland and chemoembolization is really starve that area of its blood supply, which causes pain. With radioactive beads using Sursphere or Therasphere, the idea is really to use the arteries as a highway to let these beads percolate down into the tumors, but there's not as much blockage of the blood supply.
Mm-hmm.
It's really just to let the therapy get there and sit for a long time so that the radiation every 64 hours, half that radiation is being deposited in the tumor, killing it from the inside. So I think that's probably unique to radioembolization, that you would treat the whole liver and not just treat segments or right side, left side. That being said, if somebody has a large right-sided tumor and one left-sided tumor, I would definitely treat that patient with radiation, chemoembolization, bland embolization in one setting, because I could find the highway out into that tumor, treat it. I could find the highway into the other tumor and treat it, but I wouldn't be exposing the whole liver to that kind of toxic therapy.
Yeah, I like that. I mean, you do a really great job of using the visual images to articulate and convey these concepts. So that for somebody like me, I'm a filmmaker, like that helps a lot. So I like the highway metaphor a lot. So,
thank you.
Thanks, Jennifer. Appreciate your question. Hope you're doing well. Next question from Alan. I think we've talked about this before. And Alan, I think you are a Luncheon with the Experts regular. So good to see you again. Does embolization affect PRRT? And if so, how?
Yeah, that's a great question, Alan. And that's something that's been, we've been learning, I would say, over the last decade. And as most people know, PRRT has been widely available in Europe for a long time. So I would say that our experience, and there were some resources that I had listed. One of the PDFs was a paper by Ezedin out of Germany, who did some of the early work with PRRT and Y90. What that paper said is that people who underwent PRRT and then demonstrated progression of disease were able to be treated with Y90. So yttrium-90 in the liver, either Sursphere or Therasphere. And it was safe to treat those patients. We do realize that radiation is additive over your lifetime. So there are certain things that we look at. How much did you receive during your PRRT? In general, only about 1% of the dose accumulates in the liver from PRRT. Now, that's obviously depends on the amount of tumors, the dose that you got, how many doses you had. There was another paper that was published that also echoed those same results, that it was safe to do. Dr. Sulin published a paper looking at kind of the opposite. People who had lots of liver therapy. So they'd had bland embolization, chemoembolization, radioembolization, and that's because PRRT was not available in the United States. So we did many more liver-directed therapies in the US than they did in Europe. So the patients are a little beat up because you've had lots of stuff done to your liver, and then go get PRRT. In his series, he saw that there were increased adverse events in those patients. And it's probably just a different patient population. People in Europe were getting it after failed PRRT, whereas people in the United States were getting it after failed liver therapy. So I would say in general, yes, it's very safe. In our program, we tend to wait, I'd say probably 6 months to a year after PRRT if we were going to do something to the liver with radioembolization. And I think Dr. Liu is even, we're all kind of figuring this out as we go, honestly. And do we do the embolization? Do we do a bland embolization first to decrease the amount of tumor burden so that PRRT is then more effective because there's less receptors to go after? We're doing some work in that as well.
Got it. Thank you. And thank you for your question. Couple more. I mean, we've got about 8 minutes left, so time for just a few more questions. I just want to reiterate, if we don't get to your questions, we had a lot today, and a lot of them are dense. We've got a lot of great information from Dr. Nutting. Follow up with CCF, either here on the Facebook page, you can direct message them, or carcinoid.org. And where can the people reach you, Dr. Nutting?
They could reach me at the website www.eccomedical.com. That's our practice site. My email is cnutting, N like Nancy, UTTING at echomedical.com. And I'm happy to respond and field questions. They could call me at the clinic as well.
That's very kind of you, and we'll try to include that information in the comments before we leave. Try not try not to abuse Dr. Nutting's generosity there, the CCF Army. Marcia says, "This is my first CCF visit for live streaming. Enjoyed the questions and answers. Thank you for helping us understand. That makes me feel great, Marcia. We appreciate you. Hope you come back."
Thank you, Marcia.
And I love to have experts like Dr. Nutting on here to make me look like I'm actually doing something good for people. So, okay, let's get to a couple more questions before we get out of here. There was one I saw. This is interesting. This is from Sherry. Can a fatty liver ever be misdiagnosed or misdiagnosed for NETs on the liver?
That's a good question. I don't know that I have seen that. Fatty liver tends to create a different type of tumor, which is a hepatocellular carcinoma. Usually I would say MRI is pretty good at differentiating tumor versus fatty tissue. So I don't know the true answer to that.
Got it. All right. If you have a follow-up question, Sherry, just shoot us back a comment, or you can reach out to Carcinoid Cancer Foundation. They'll try to get you the help that you need. Casey says, "Hey, Dr. Nutting, you treated my mom, Linda. We loved working with you. Thanks for all your help."
Thank you, Casey.
They love you, Dr. Nutting. They love you.
My love.
From Sandra, I have read that surgery to remove a typical carcinoid tumor with its surrounding tissue is essentially a cure for the disease. Do you think there's a chance of another tumor popping up somewhere else later on? Or I guess the question is, what are the chances?
Yeah, so the chances are pretty good that it depends what we're talking about, primary tumor versus metastatic tumor. And, you know, what's really impressed me is the surgical capabilities right now that the NET specialists have in being able to go into the liver and remove these tumors. Most of the time, if you're doing a liver surgery to remove a tumor, you want to get an R0 resection, which means that there is absolutely no tumor left behind. With neuroendocrine disease, it's much more common to do a debulking surgery where you actually, you know, take the bigger tumors out, the ones that are surgically accessible, but you may leave some disease behind. And that's perfectly okay, because we know that by debulking the disease, patients are going to do better longer. And disease that's left behind, they could have a surgery maybe in another 5 years. They may get some liver-directed therapy that they don't have to actually have an incision, like by somebody like myself. So I would say if you catch something early, yes, there's a possibility that it is a cure. If it's already metastasized, I think it's probably unlikely going to be a cure, but can help stabilize the disease for a long period of time.
Got it. Thank you. I think we probably have time for one more. Lee says, "Do you use octreotide in every embolization?"
I do. And I think that's at the guidance of Dr. Liu and our team. Octreotide is a very well tolerated drug with minimal downside. So I always err on the side of caution. It may cause a little bit of nausea. We give it IV slowly, but we have Zofran and other medications to counteract that. Those of us who do lots of this and have ever seen a true carcinoid reaction on the table, it gets everybody's attention, and it's much easier to be preventative from the beginning than it is to try and manage it in the middle of the surgery.
Got it. Thank you for that. And thank you for your question, Lee. Hopefully that helps. Before we go, Dr. Nutting, a question I always like to ask, you know, you've talked about patients being their own best advocate. You've talked about the importance of a multidisciplinary team. What's the first piece of advice you would give to a newly diagnosed patient with a NET? I mean, where do they start? They're confused. They're scared. This is a rare disease.
Yeah, I think you hit it on the head, right? It's a rare disease. So you want people that deal with this day in and day out. You want the experts. So CCF is a good resource, and I'm sure has a doctor finder page. I think, you know, if it were a family member of mine, the first thing I would do is figure out who's the expert in the area, have that patient evaluated at a multidisciplinary NET conference. And I don't think a second opinion is bad. Honestly, I welcome second opinions, and I like my patients to get second opinions. I think it makes everybody better. So there are lots of good resources available on the net. CCF is one of them.
Outstanding. And I just got to say, like, the humility that I see in the experts in this disease and in this community is outstanding. And it really is a community, and people want the best outcome for the patients of this disease. And I don't know, that's just something that always makes me feel really good. You don't see a lot of competition. You see a lot of collaboration, and I think that's what it takes. And it makes me happy to see that. So that's it for today's show. Thank you, as always, for joining us. We hope this program helped with some of your questions. I'll reiterate one more time. If we didn't get to all your questions, you can reach out to Carcinoid Cancer Foundation, either here at the Facebook page or carcinoid.org if you have further information. Thanks again to our presenting sponsor, Lexicon Pharmaceuticals. Without them, this program wouldn't be possible. Special shout out to Dr. Liu, lurking in the video like the Phantom of the Opera and chiming in. And a huge thanks to you, Dr. Nutting. We appreciate your time. This was great. I appreciate it.
Thank you so much. Thanks for having me.
Absolutely. All right, everybody, stay healthy, stay safe. My name is Rain Bennett. Thanks for watching, and join us next time for Luncheon with the Experts. Bye-bye, everybody.
Bye, guys.